Good afternoon, ladies and gentlemen. We want to talk about the impact of early life stress on health and disease. My name is Rainer Buchhorn, and I start my research at the University of Göttingen in infants with severe heart failure. Based upon this experience and the first betablocker therapy in infants with severe heart failure, we further developed a model about autonomic dysfunction in children based upon heart rate variability analysis. Later, as head of the Caritas Hospital in Bad Mergentheim, we additionally try to understand psychosomatic diseases like ADHD by analyzes heart rate variability and develop new therapeutic approaches like the treatment with omega-3 fatty acids.
There are many phases of early life stress in early infancy. Early life stress may be related to starvation in some countries. It may be related to severe disease like heart failure in congenital heart disease, or it may be related in prematurity, for example. The research to investigate the impact of early life events on long-term health and disease was called Developmental Origin of Health and Disease research. Today there are epigenetic models which suggest a complex early lifehood imprinting process in the first 1,000 days of life. We investigate the impact of early life stress on the autonomic nervous system called the concept of autonomic imprinting. Early life stress is due to intrauterine growth delay, stunting, heart failure, prematurity, inflammation, social deprivation or neglect, for example. The developmental disorders are short stature, cognition impairment like attention deficit hyperactivity disorder, and perhaps obesity. The long-time cardiovascular risk is increased by hypertension and the metabolic syndrome.
By using the term autonomic imprinting, we remember on the research of Konrad Lorenz, who tried to explain long-lasting effects by early life events. Today, modern genetics may explain these effects with epigenetic modification of the genome.
This slide summarizes the current understanding how early life stress in like prenatal maternal stress, early postnatal stress, or childhood adversity have an impact on the brain, on the HPA axis, immune dysregulation, brain developmental disorders. In summary, the author of this slide expect more anxiety, depression, schizophrenia, cognitive impairment, and the metabolic syndrome as the consequences of early life stress. The political consequence of the developmental origin of health and disease theory uh, is an improvement of nutrition for mothers and children as one of the most cost-effective and impactful tools that we have to poverty alleviation and sustainable developmental improvement. Our group and others had shown that early life stress is measurable, for example, by norepinephrine levels or heart rate variability analyzers. In this slide, there are the higher norepinephrine levels in preterm infants who develop disability or death, those with univentricular hearts, and most of all those with congenital heart disease and Down syndrome. All these infants have higher norepinephrine levels and lower heart rate variability.
Analysis of heart rate variability is not really new. There are reports about Chinese doctors who use pulse diagnostic to predict the death of their patients. But today we have new technologies to analyze heart rate variability, for example, with such an 24-hour Holter ECG. Most of our studies based upon this technology. Moreover, today everybody has the opportunity to measure his own heart rate variability with a fitness tracker, and sometimes our patient will understand more than the doctors how to use it. The newest technology is to monitor heart rate variability in an intensive care unit setting. We have self-made technology to monitor our patient on a pediatric intensive care unit, but there are professional systems used in this setting. First of all, we have to understand that we use a normal heartbeat, the so-called sign of the rhythm, to understand the main regulatory system of our body, most of all the limbic system and the hypothalamus-hypophysis axis. That is an important issue to understand that we use the heart to understand the brain. The method based on the difference between the single heartbeats or NN intervals to analyze the variability with statistic methods or the fast Fourier analysis.
One of the most important issues to understand is the changes of heart rate variability in the human's life cycles. There are very low heart rate variability measured as with the spectral analyzers or the time domain analyzers at birth, with high heart rates about 140 beats per minute. There's a steep increase of heart rate variability and a decrease of heart rate in the first 1,000 days, and a further increase in puberty with the highest heart rate variabilities in an age of 12 to 13 years. In later life, the heart rate remains stable and the heart rate variability decreased. Most of all the vagus activity indicated in green, the RMSSD value as a line, and the high frequency power, who is nearly zero at the end of our life.
There are important intra-individual differences of heart rate variability in the human life cycle. There is a steep increase in the first 1,000 days of life and a further steep increase during puberty. Most people have heart rate variabilities within the gray area, but some have lower heart rate variabilities illustrated as red, or high heart rate variability illustrated as green. The underlying diagnosis are obesity with a very low heart rate variability or attention deficit disorder who have also very low heart rate variability, as well as children with short stature. Early in life, infants with congenital heart disease or after prematurity have very low heart rate variability. At the other end, there are athletes or children with anorexia nervosa who have very high heart rate variability. There is a high evidence that heart rate variability is related to prognosis. Those with very low heart rate variability have a high cardiovascular risk or risk for inflammation and have the highest risk to die.
One of the most difficult problems of the model of autonomic imprinting is how to simplify the complexity of this model. I try to simplify the early life stress model on three topics. The first topic is the short stature. This is very well measurable. The neurodevelopment and the cardiovascular risk.
The developmental origin of health and disease hypothesis overcome the limitation of the current genetic models to explain the origin of disease. For example, this paper in Nature about the human height shows that only 10% or 3 centimeters of the variance of human height is explainable by genomic differences.
We have realized that our patients with short stature below the third percentile due to intrauterine growth delay or congenital heart disease have a very low heart rate variability as measured by RMSSD in infancy as well as in later life. In 2016, we published our concept of autonomic imprinting in children with short stature in +1. We clearly show that not the short stature per se is the problem if those children with constitutional growth delay and those with growth hormone deficiency have no reduction of heart rate variability. But those with intrauterine growth delay, with cardiac growth delay, and syndromal growth delay have higher heart rates and lower heart rate variabilities. Moreover, we realize that many of our children with short stature have the problem of attention deficit disorder indicated by the red dots in the left slide. For example, there's a young man with intrauterine growth retardation and a birth weight of 700 grams who develop short stages that were treated with growth hormone and attention deficit disorder treated with methylphenidate, later with guanfacine, and in adulthood further methylphenidate. However, we have a clear contraindication due to the high blood pressures and the low heart rate variability that was not realized by other doctors. However, the patient decide, despite this high cardiovascular risk, further to treat with methylphenidate. We think that is not a good idea to treat those infants with stimulants if these patients are one of the patient group with the highest cardiovascular risk. The non-fatal cardiovascular events are very high in patients with attention deficit disorders and patients who are treated with growth hormone therapy. The odds ratios are clearly higher than for hypertension and an elevated body mass index. In detail, the Swedish data from the national registers are the best we have. And indeed, attention deficit disorder and growth hormone deficit have the highest risk for coronary heart disease, myocardial infarction, stroke, and the cardiovascular death, compared to a lower risk in those with hypertension. And we have to realize that those with the highest resting heart rate have the highest risk to develop heart failure. But what to do with these kids with adverse events in early childhood? The best chance to treat early life stress is in early life, in the moment when the children suffer from early life stress. In later life, we have no good opportunities to improve the situation. Our treatment has to start in infancy. And again, we can measure early life stress by norepinephrine levels or heart rate variability. In this slide, the group who analyzed the data of premature infants show a level of 1,500 nanogram per liter norepinephrine that indicates an elevated risk for death and disability. We clearly show that our infants with congenital heart disease, with heart failure, have uh, elevated norepinephrine levels in this range comparable with the norepinephrine levels early after cardiac surgery that are even in the same range as uh, in daily life situations with heart failure. It is much better not to suffer the infants with a blood examination, and we can simply measure heart rate variability in the ECG and find that our patients with heart failure have low RMSSD values as well as low SDNN values, who indicates the early life stress in those infants with congenital heart disease due to heart failure. Um, and these are the data compared to healthy controls. Patients with congenital heart disease without heart failure have normal norepinephrine levels, even lower heart rates, normal heart rate variability. Uh, Those with heart failure treated with digoxin and diuretics have the highest norepinephrine levels and the lowest heart rate variability as indicators for early life stress. We can improvement with a simple propranolol therapy. The infants have lower heart rates and normal heart rate variabilities that indicates a significant improvement of early life stress with propranolol therapy.
This chart is showing the monitoring of heart rate variability of an infant with severe heart failure due to a truncus arteriosus communis. The baby have very low heart rate variability at the 10th day of life of caused heart failures despite the therapy with metoprolol, a betablocker, and diuretics. She had no weight gain. After changing the therapy to the beta-blocker propranolol, after reducing the diuretics and additional digoxin, the baby have increasing heart rate variabilities and increased weight up to the operation at the day of 14 days. The baby was operated with a weight of 3.5 kilograms and have successful cardiac surgery in a center. The baby come back to our intensive care unit at the 55 day of life again with severe heart failure, and we change again to propranolol, and we are happy to observe a steep increase of heart rate variability up to the 75 day of life. At this moment, the baby is nearly normal. She don't need nasogastric tube, and she can go home without any problems.
We developed our early life stress model from 2005 to 2023. We realized that early life stress measured by heart rate variability or norepinephrine levels have an impact on neurodevelopment, for example, the attention deficit disorder. Others show that cytokinesis failure is related to higher norepinephrine levels that may improve with beta-blocker therapy that leads to an improvement of myocardial dysfunction. We could show in the next slide the model of autonomic imprinting with a better heart rate variability after propranolol therapy, and we hope that we can reduce the cardiovascular risk. There are an impact of endothelial dysfunction and pulmonary hypertension, and perhaps we may improve short stature and children with severe congenital heart disease. Looking to our data, the growth is best shown in our infants who are treated with propranolol due to severe heart failures and Down syndrome. These infants have lower height at birth, and at the time of surgery, the height is normal after propranolol therapy. There's a small decrease up to the first year of life and a very good height in later life. Compared our infants with Down syndrome and congenital heart disease with the growth of other groups measured in South Africa, Brazil, and our Down patients who are treated with standard therapy by other cardiologists, there's a clearly better growth in children who have received propranolol. You have to realize that the cognitive impairment is related to growth in infants with Down syndrome, and there may be an impact on neurodevelopment in those infants with Down syndrome who have a better height. I try to explain the main consequences of our model of autonomic imprinting in infancy in the whole group of patients with operated congenital heart disease in that longtime. In total, these are 224 patients. Starting in infancy, we have to realize that 50% of patients who die from congenital heart disease are infants. A low high-frequency power, indicated in green, indicated the high mortality of infants with significant lower high-frequency powers in our group. Congenital heart surgery is the most effective therapy to improve the situation. The rule of percutaneous intervention is unclear. Guideline recommendations for dioxin ACE inhibitors and vasodilators are not supported by prospective randomized trials for more than 50 years. However, the preoperative beta-blocker treatment with propranolol in infancy improve clinics and heart rate variability in a prospective randomized trial. Our long-time data after beta-blocker therapy in infancy show normal heart rate variabilities and probably better physical performance that have to be proven. It has to be proven if preoperative beta-blocker therapy of heart failure improve heart rate variability, maximal oxygen uptake, and outcome after surgery of congenital heart disease to really find a solution for the question of the concept of autonomic imprinting. In later life, physical performance and the maximal oxygen uptake impair with higher ages. The maximal oxygen uptake after surgery of congenital heart disease depends on age and heart rate variability. The long-term survival depends on maximal oxygen uptake and heart rate variability. Current therapies with beta blockers, ACE inhibitors, AT1 antagonists, bosentan, and sildenafil didn't improve maximal oxygen uptake and probably heart rate variability. Pulmonary valve replacement as the most often procedures in this patient didn't improve maximal oxygen uptake and probably not improve heart rate variability. Sports intervention and lower body mass index probably improve maximal oxygen uptake and perhaps heart rate variability. Perhaps SGLT2 inhibitors may improve maximal oxygen uptake and heart rate variability in this group of adults with operated congenital heart disease, but this have urgently be proved.
Taken together, we can differentiate three cohorts of our patients with congenital heart disease and cardiomyopathies. There's the current concept group with high heart rate variabilities. There is a conventional group treated with digoxin, diuretics, and ACE inhibitors, and these patients have the low heart rate variabilities as published in many papers. The longtime cohort is the first cohort with normal and enhanced heart rate variability in long-time follow-up after cardiac surgery. The third group are children with cardiomyopathies and ventricular dysfunction who have very low heart rate variability and a bad prognosis and need heart transplantation or they died.
And again, the total of 19 infants with severe heart failures who are treated with propranolol in longtime show normal heart rate variability and RMSSD values on long-term follow-up. Also in the frequency domain analyzers, the patients indicated in lines have completely normal heart rate variabilities measured by the spectral analyzers, and the heart rates are completely normal in this group. We now realize that the betablocker treatment of infants with heart failures is the most effective therapy to improve heart rate variability in infants, with a steep increase of the RMSSD values by 18%, the SDNA values by 20%, and a lower heart rate. The patient group with hemangioedema who are treated with propranolol and have no early life stress have a lower effect on heart rate variability compared to the infants with heart failure who receive propranolol. Looking to all the patients in our prospective study who are treated with bisoprolol after with heart failure after surgery of congenital heart disease, there are only small effects on heart rate variability and heart rate in this patient group. It seems that it is too late to treat this patient with beta blockers to improve their heart rate variability and their clinical condition.
Those who are interested in this concept of autonomic imprinting may read my book about diagnostic and therapy of regulation disorders of the autonomic nervous system in children and adolescents, at this time only written in German. Thank you for your attention.